What's up, everybody? Welcome back. In today's video, we're going to be going over hemodynamics. Now, a common misconception with hemodynamics is that if you have a good blood pressure, then you have good hemodynamics. This is not correct. You can have someone with a blood pressure of 120/80 and they're not on any drips. Their fluid balance is good. That person probably has good hemodynamics. But you can have somebody with a blood pressure of 120/80 and then be on 3 pressors. Now, obviously, just because the blood pressures are the same across those two patients does not mean that they're both hemodynamically stable. Obviously, the patient who's on 3 pressors is not hemodynamically stable. So, in this talk, we're going to be breaking down hemodynamics, all the numbers, what they mean, and how certain medications affect those numbers. Okay, so let's start talking about the 3 pillars of hemodynamics, which are preload, contractility, and afterload. So the first one we're going to talk about is preload. So preload is the pressure due to volume in the ventricles I was going to say before, but at the end of diastole. So basically, when the heart is relaxed and the ventricles are open and they're filling up with blood, this is going to be the volume. So the pressure in those ventricles, due to all that blood in them, that is your preload, okay? And what preload is this is at the end of diastole. So when the ventricles are completely filled with the blood that they are going to eject. So we measure preload on 2 sides of the heart differently. So we measure on the right side and we measure it on the left side. So on the right side, we measure with CVP, central venous pressure, which is around 4 to 10 millimeters of mercury. Okay, there are lots of cheat cards where you can see what your normals are. So by no means do you have to memorize them, but if you're in critical care, you should try and memorize as many of this stuff as possible. But it's not completely necessary when you're first starting off. So on the left side, we measure with pulmonary artery occlusion pressure, also known as pulmonary artery wedge pressure or pulmonary capillary wedge pressure. These are all basically the same thing, and this normal is around 8 to 12 millimeters of mercury. So we will get our wedge pressure with a Swan-Ganz catheter. So that is a pulmonary artery catheter. So this is a catheter that's placed in through the IJ or subclavian, and what it basically does is it's going to go through the right side of the heart, so through the right atrium, right ventricle, and it's going to float up into the pulmonary artery. So from that point, then we can inflate a balloon on the end of that catheter, and that back pressure on the balloon is going to tell us what our wedge pressure is. And we're calling it wedge because when the balloon is inflated, it's wedged in the pulmonary artery. So on the right side, we measure preload with CVP. On the left side, we measure it with wedge pressure. So if they have an increased preload, this is associated with increased volume. So their volume overloaded. Okay, so we would treat them with diuretics, maybe some dialysis, or if they're hemodynamically unstable, CRRT. If they have a decreased preload, this is associated with volume deficit. So they're dehydrated, okay, or they are bleeding. So we would treat them with IV fluids, blood. At my facility, we use a lot of albumin since we're dealing with liver failure patients. So there are 2 kinds of albumin that we can give. We can give 5% or 25%. Now, the great thing about albumin is that the 25% albumin is more concentrated than the blood. So when we give 25% albumin, that's actually going to pull fluid from the interstitial space into the vascular space. Thereby, it's increasing our oncotic pressure, right? The 5% albumin is not going to do that as much, but the 25% albumin will. So if you have a patient who's third spaced and they have fluid on them, it's just not in their vasculature, albumin's a great medication to give. So that is all things preload. Now let's talk about contractility, okay? So I'm going to erase this. Okay. So contractility this is relating to the force of contraction, also known as the squeeze, right? So how hard is our heart squeezing, okay? So with contractility, the way we can measure this is with an echo gives us ejection fraction, okay? Which is equal to the percent of blood ejected from the ventricles. This is around normally 65%, okay? So of the blood that goes in the ventricles, a normal heart will only eject 65% of it, okay? So all the blood that's going in your heart, it's not being ejected out. Only 65% of it is the normal that it will, okay? So, and then once you start getting, below around 50, you're getting into heart failure mode, okay? So we can actually increase or decrease the heart's contractility or the force of contraction. And the medications that do this are inotropes. So we have positive inotropes, and positive inotropes increase contractility. So some of the medications that are positive inotropes include dopamine, dobutamine, Primacor, also known as Milrinone, Dig, Epi. These are all positive inotropes, okay? Negative inotropes, trying to stay inside my screen here that you can see, these decrease contractility. So this is going to be your beta blockers and your calcium channel blockers. Hopefully you can still see that. Okay, so if our patient has poor contractility, maybe they have a dilated cardiomyopathy, etc., we could give them positive inotrope. This is going to increase the contractility of the heart. Okay, the last of the three pillars we're going to talk about is afterload. Okay, so afterload is the pressure. This pressure is due to resistance. That the ventricles must overcome to eject blood out of the heart. Okay, so think of afterload as, say you're trying to open a door and that door opens outward, and then say there's a giant rock on the other side of it. You not only have to push that door open, but you have to push it against that resistance that's coming back on you. So if there's a lot of resistance, then it's going to be more difficult for you to eject blood. If there's not a lot of resistance, then it's going to be a lot easier to eject the blood, okay? So we measure afterload on the right side and the left side differently, okay? On the right side, this is like similar to with our preload. On the right side of the heart goes to the lungs. So since this is related to resistance, we're going to measure right side afterload with pulmonary vascular resistance. This resistance is a lot less than that of systemic vascular resistance, which is the measurement for afterload on the left side. So PVR normal is going to be around 150 to 250 dynes. And SVR, a normal is going to be around 900 to 1400 dynes. Okay, so that's how we measure it. SVR, to calculate it, this is your map. To calculate your PVR, this is going to be your PA mean minus your wedge pressure divided by your cardiac output, and you're going to multiply all this by 80. Your SVR is going to be your MAP minus your CVP, and you're dividing this by your cardiac output, and you multiply all that by 80. So you have to have CVP or your wedge to calculate this. So if you have a hemodynamic monitor like the EV1000, etc., then you need to have this information in order to calculate, or a SWAN. You need to have this information. So let's talk about what these are associated with. So if you have elevated afterload, this is going to be associated with the patient being vasoconstricted. So we treat with vasodilators. This is going to be nitro, morphine, cardine, any of those, right? If we have decreased afterload, this is associated with vasodilation. So we treat with vasopressors. Your 5 pressors are going to be levo, vaso, epi, dopa, and neosynephrine or phenylephrine. Okay, so my facility, we always go levo, vaso, epi, dopa, neo. These 3 we can kind of switch it up. Basically, once they need a 3rd pressor, that's not really good. So we have to start making talks about what other things we can do to treat this massive vasodilation. And there's more medications coming out that treat vasodilation, like new pressors and stuff like that. But currently, these are the ones that my facility uses. So we've talked about preload, we've talked about contractility, and we've talked about afterload. So we know what these concepts mean, and now we need to see how they relate to a few things, okay? So we have preload, contractility, and afterload. All of these are going to affect stroke volume. And stroke volume is the mLs pumped per beat. This is around 60 to 130 mLs. Okay, you multiply stroke volume times your heart rate, and that's going to give you cardiac output, which is liters pumped per minute. And this is around 4 to 8 liters. Okay, that's your normal. So the amount of blood that your heart pumps in 1 minute, your stroke volume, directly relates to how much blood was in there in the first place. That's your preload. How hard your heart is pumping, and how difficult is it for the blood to get out of the ventricles. So how difficult is it for the heart to pump this blood out? Okay, you multiply however much blood exits the heart in one beat by their heart rate, and that gives you cardiac output. Your cardiac output has a direct relationship with your blood pressure. Remember, we said hemodynamics does not equal blood pressure. Okay, but your cardiac output relates to your blood pressure. Okay, so that is how all these things relate to one another. So we should not be looking at the blood pressure and being like, oh, that blood pressure is good, and thinking that this person has good hemodynamics. If this person has good stroke volumes, then they have probably good hemodynamics. Okay, but yes. So let's kind of break down heart rate a little bit. So increased heart rates and decreased heart rates are not good. Okay. So if a person is tachycardic, maybe they're an SVT, AFib, RVR, whatever, their heart rate is elevated at this time. So when the heart rate's elevated, then there's going to be less filling time. So your preload's going to be changed. With decreased heart rate, you can have a normal stroke volume, but if you have a decreased heart rate, your cardiac output is going to be low. When the cardiac output is low, this is going to mean there's less blood being pumped by the heart. And there's the less blood that's being pumped by the heart, the less blood that's going to your brain, your lungs, your actual heart, your kidneys, your liver, your extremities. And that's when you're going to then become symptomatic. So when somebody has a low cardiac output, or maybe their blood pressure is low, they probably have that low cardiac output because that one of these three things is wrong. And then they are getting poor blood flow. So then they become altered. They get chest pain, they get shortness of breath, they start to get anxious, feeling like they're gonna die, like this impending doom feeling. That's whenever you got something that's they're no longer compensating, and that's whenever you need to act now. Okay, so that's where the symptomatics come into play. So again, back to what I was saying, with elevated heart rate, you have less filling time. So that's going to eventually change your cardiac output, and then they will become symptomatic. That's why somebody in SVT that is or that is asymptomatic, we are going to treat them, but we'll probably treat them with, maybe we'll give them some amiodarone. But if they're symptomatic and they pass out or they're having shortness of breath, that's whenever we're going to be like, okay, we need to give them some adenosine and we need to get this heart converted as much as possible. With bradycardic patients, we can give them, atropine. We can give them, put them on a dopa drip to increase some kind of chronotropic drug. Chronotropic drugs affect heart rate. So if we give them some dopa, that'll increase their heart rate, etc. But we usually, if they're bradycardic and they're not symptomatic, then where's the problem, right? But once they become symptomatic, that's whenever we need to start fixing stuff. So maybe someone comes in 3rd degree AV block, they're bradycardic. Well, if they're symptomatic, then guess what? We're going to give them a dose of atropine. If that doesn't work, we're going to transcutaneously pace them and get them to cath lab, or we're going to place where they can get a transvenous pacer, or we'll place it at bedside. Okay, so that is that. I do want to talk about a few things in addition. Let's talk about index values, okay? Because you're going to see index values on your cardiac output monitors and your hemodynamic monitors and all this stuff, okay? So index values. Examples of these are going to be your stroke volume index, your cardiac index, your SVR index, etc. All these index values, they're basically the value but related to body surface area. So whenever you're thinking about index values, think about Shaq, okay? Shaquille O'Neal. I'm a Spurs fan, so I don't really like Shaq, but nothing against Shaquille O'Neal. That's just me, okay? I'm a major Spurs fan, but respect to him. But think about Shaquille O'Neal. So we've talked about cardiac output. We said the normal cardiac output is around 4 to 8 liters. So say me, I have a cardiac output of 4. Okay, that's normal, right? And then we have Shaquille O'Neal, which Shaquille O'Neal's not here, so he can't, be a reference. But Shaquille O'Neal's a lot bigger than me, okay? So say his cardiac output is 4. Well, that shouldn't be, we shouldn't have the same cardiac output. If we have the same cardiac output, then he's gonna feel horrible. So we could have the same cardiac index though. We could have a normal cardiac index, and he have the same as me, but that just means that it's our cardiac output but related to body surface area. So you want to really keen into index values when you're dealing with these bigger people and these smaller people, okay? Because things will change, all right? So that's index values. The last thing I want to talk about is Frank Starling's law, or Frank Starling's curve, okay? So the Frank Starling curve. This is a curve that is relating to our preload and our stroke volume. And the curve looks like this, okay? So basically the idea behind this is you have a hypotensive patient. What's the first thing we always do? Let's give them a bolus. Let's give them fluid. So we can give them volume. That's going to change their preload. That's going to increase their preload, which means it's going this way, right? So as we increase preload, their stroke volume is going to increase. But at a certain point, like right there, it plateaus, right? So at a certain point, it doesn't matter how much volume we give them, their stroke volume is not going to change. Okay. In fact, at this point, all this time over, they're just going to be more and more volume overloaded. And we all know wet lungs are not happy lungs. So this is going to be the time when you're going to develop pulmonary edema. The person's going to get short of breath, and guess what? They're either going to need BiPAP or they're going to need to get intubated, right? And nobody wants that, okay, unnecessarily. So how do we know where they are on this curve? Well, where they are on this curve is going to be their stroke volume variance, okay? Stroke volume variance. So this is the variation in stroke volume over time. And this is going to add up to a percentage, okay? So we want their stroke volume variance to be 0. Sorry, the video cut out and I actually had already changed, so I'm gonna get back into it. The last thing I was talking about was you need to fill your tank before you press on the gas. So you want to make sure that volume is not an issue here. If you are driving in your car and you have an empty tank and you press on that gas, you're not pressing down on anything, so your car's not going to run. So you always need to make sure you fill your tank, then you can press on your gas, meaning you want to make sure they're volume optimized, and then you can go ahead and you can put on, you can put them on pressors or put them on inotrope, etc. So as far as giving your patients volume, you want to essentially give them preferably smaller boluses and not huge boluses, and be monitoring their stroke volume variance. Now, whenever you're giving patients boluses, basically, if you don't have a hemodynamic monitor that can monitor your stroke volume variance, like an EV1000, then you want to basically give them a small bolus, see if their blood pressure improves. If their blood pressure is not improving with the small bolus, then it probably won't improve with the large bolus. But if it is improving, then give them another little bolus, and another, and another, and another. Once it stops being effective, then we need to stop, okay? Because then we're going to overload our patients, put them in pulmonary edema, and then they need to get tubed or yada, 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 and it's not fun. So fill your tank before you press on the gas. This is where they are on this curve is your stroke volume variance. So whenever they're right here on the curve, their stroke volume variance is actually high. When they're here, it's 0. Okay, so what we want is we want them to be right, we want them to be right there at 0. We don't want them to be beyond this curve. If they're right here, 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 we can give them fluid. Okay, we give them a little bolus. Give them a little bolus, we see it improve. We give them another little bolus, we see it improve. We give them another little bolus, we see it improve. We give them another bolus, we see nothing improves. We stop giving fluid. If they're still hypotensive, then what we can do is, if they have a normal stroke volume but a low cardiac output, give them an inotrope. If they have a low stroke volume and a low cardiac output, give them a pressor. Okay, so that is hemodynamics for you. So we went over the 3 pillars: preload, contractility, afterload. We talked about how those are affected by different medications. We talked about how each of those affects stroke volume, how stroke volume is your big major key there, how heart rate affects your cardiac output, and how cardiac output is related directly to blood pressures. And so then we talked about index values, and we talked about Frank-Starling's curve. So that's just a little bit into hemodynamics. There's so much more to learn. So please, if you have any questions, let me know. But that is the end of the video. I hope you enjoyed it, and have a good rest of your day. I'll see you in the next video. Bye.